Thank you. Okay, welcome everyone. Good afternoon. Hopefully you've enjoyed some lunch and maybe some lunch dessert. Thank you for coming to our early afternoon talk. So this presentation is going to cover establishing RAAM clinics. I'm going to introduce our incredible panel of speakers and then we'll dive into it. So Kate Hardy, if you want to give a wave, is the Administrative Director of the PHI program, which she helped found in 2015. In this role, Kate collaborates with local, regional, and provincial bodies to improve healthcare delivery and accessibility through the RAAM clinic model of care. Kate holds master's degrees in social work and healthcare administration, which help inform her efforts to advocate for in-person, centered and accessible care. Kristen Kerr, so boss number 1 for me, in case anyone didn't know that. Boss number 2 for me, Kristen Kerr is a registered social worker and CEO of Stonehenge Therapeutic Community with over 15 years of experience in mental health and addiction services. She leads efforts to create welcoming, supportive communities for individuals with substance use challenges. Under her leadership, Stonehenge offers a range of services, including a 42-bed residential treatment program, supportive housing, addiction medicine and withdrawal services, and community-based harm reduction programs. Kristen is committed to advancing health equity and driving system change to improve care for vulnerable populations while fostering a strong organizational culture and staff engagement. And last but very not least, Michael, do you want to give a wave? Thank you. Is the clinical manager for regional outpatient addictions programs at HSN in Sudbury. He is the regional lead for the rapid access addiction medicine clinics in northeastern Ontario, providing administrative support to RAAM clinics throughout implementation and optimization. He is also the manager of HSN's RAAM clinic and outpatient addiction and gambling service. He is an advocate for implementing innovative approaches to substance use treatment and enhancing harm reduction initiatives in hospital and in community settings. Michael provides leadership for both local, regional, and provincial substance use treatment and harm reduction initiatives in urban, rural, and remote settings. He is a registered nurse with varied background in education, nursing regulation, mental health, and community health. And I will welcome them up now.
Hi, everyone. Good afternoon. I'm realizing I probably should have done some practice with this ahead of time, but welcome to our talk on establishing RAAM clinics and really focusing on the steps required to implement any kind of low barrier substance use service. Just once again, very quickly, I'm Kate Hardy. I'm the Administrative Director of the PHI program, and I'm joined up here by Kristen Kerr, the CEO of Stonehenge, and Michael Roach, the Clinical Manager of Regional Outpatient Services with Health Sciences North. We don't have any financial disclosures or conflicts of interest to report. I'm going to start us off with just a brief overview of the PHI program in case anyone isn't familiar with our work. And I'm also going to talk a little bit about why we are sort of well positioned as a program to speak to how to set up a low barrier substance use service. So just to start off with, PHI is a provincial initiative. We are funded by the Ministry of Health in Ontario. And our purpose is really to support healthcare workers that work with people who use substances, primarily in the RAAM clinics across the province, but really across a multitude of different settings, including primary care, emergency departments, withdrawal managements, and so on. And we really try and accomplish this through 5 main program pillars. And that includes networking and integration, oversight, education and clinical guidance, mentorship, and standards and policy. So I'm going to dive into that oversight pillar a little bit more now. And as a bit of background, in 2020, PHI became the central hub for Ontario's network of publicly funded rapid access addiction medicine clinics, of which there are now more than 80 across Ontario. And as part of our central hub role, we manage a provincial directory of RAAM clinic sites. You can find that on our webpage, medify.ca. And we also set quality targets for these publicly funded sites, which are really intended to help sites think about how to best offer high quality, low barrier substance use services. And then we oversee an annual survey that's disseminated to all 80 plus RAAM sites and then produce a report annually based on those survey results. I'm going to briefly hand it over to Kristen now to talk a little bit about who she is and her role in organization. Great.
Hi, everyone. Kristen. I'm here representing Stonehenge and our network of RAAM clinics. So Stonehenge is an addiction treatment, community-based addiction treatment organization. We're located in Guelph, Wellington, primarily providing service there, but also some across Waterloo region. As Katie mentioned at the beginning, we have a big cross-section of services along the harm reduction treatment continuum, particularly for this talk today. Relevant to know that we have a variety of RAAM clinic settings, including bricks and mortar, a mobile clinic van, and a digital front door, which is a fully virtual platform for RAAM clinics. So we've really found over the years that tailoring the type of clinic to our geography and our population is really important. And I will talk with you more about that over the course of our talk today.
Hi, everybody. My name is Michael Roach, and I am the clinical manager for Regional Outpatient Addiction Services. It is a tongue twister, so I do apologize for everybody who has to say it. So I'm here representing Health Sciences North, and we have a single RAAM clinic that runs a brick and mortar clinic right downtown in Sudbury, Ontario. We also do have a virtual front door as well, so we have access to the digital front door and the digital care. Couple of highlights for us. We are a tertiary hospital. We are located in Sudbury, Ontario. We do provide services across the greater Sudbury region. We also play a regional role. So my role, in addition to being manager, I also am the regional lead for the Rapid Access Addictions Medicine clinics in Northeastern Ontario, which essentially means I help to, one, establish RAAM clinics, spread the Medify RAAM model, and help standardize the clinics to the best of our ability throughout the Northeast. I'm going to be talking a little bit more about that as we go, and I'm going to hand it back over to Kate.
Thank you, Kristen and Mike. So now just to get a little more into the details of the Rapid Access Addiction Medicine care model. So RAAM clinic, as was addressed in one of our earlier sessions this morning, is really a very flexible model, but at the core, it's meant to be a low barrier drop-in service that provides substance use related care services support. So even though it is very flexible, there are 4 core principles to the model that we strive to have all sites adhere to. So they should be low barrier, sort of as mentioned, no appointments or referrals required. They should be comprehensive, which really means that right from the first visit, when the person first attends the service, they should be offered medication, pharmacotherapy as appropriate, if indicated, as well as counseling, harm reduction, education and supplies, as well as be provided with community referrals as needed. RAAM clinics should be integrated within the broader health care system and really have strong connections to community partners like withdrawal management, primary care, hospitals, Emerge, and so on. And very importantly, RAAM clinics should be people-centered. So services are covered by OHIP for Ontario residents, but really the goal is that the care plans are developed collaboratively between clients and the care providing team. So the goals of the care plan should really be set based on what the client identifies as their needs and priorities. The model is also meant to be flexible in terms of what the clinic looks like, and this is in recognition that there's a great deal of variability across the publicly funded sites in Ontario. Sites are resourced very differently across the province. They have access to different health human resources, different kinds of access to space. Some are located in CHCs, some are in withdrawal management, and all of that is okay as long as the sites really do strive to adhere to these 4 core principles. So now we're going to get a little bit more into the meat of it and actually the sort of steps of starting a RAAM clinic. So at this point, I'm going to make a plug for MediFi's newest product. It was just launched and added to our website yesterday. So a big thank you to my team for making that possible. You can find this new toolkit, which we're calling the RAAM Clinic Toolkit, through the link up on the screen or through the QR code. And really the toolkit contains the A to Z of materials for how to set up and operate a RAAM clinic. So this does include resources on hiring, funding, data collection and evaluation, really everything that you'd want to consider as a RAAM clinic medical director or clinic lead or sort of administrator who has a RAAM in your portfolio. This toolkit was created by clinical and administrative RAAM leads, as well as people with lived and living experience from all over the province. So one of the features of this toolkit is an implementation checklist. And there's an abridged version of it up on the screen here. And the checklist is sort of broken down into 4 buckets, which include assess, develop, implement, and evaluate. And the bolded items within the checklist are the features that we're going to focus on throughout the rest of today's talk. So the first bucket that we'll get into is assessing the potential for a RAAM clinic program. And the subcategories will include identifying key partners, how to identify the clinic location, and how to gain support from your organizational leadership, as well as government partners. So in terms of identifying the key partners for your RAAM clinic, this should really be one of the first points that you consider when thinking about starting a RAAM program. You really want to make sure that you have strong connections with your community partners. Firstly, so that once you are up and running as a RAAM clinic, you have people that are actually sending you patients, sending you clients. And then also you need places to refer these clients back out to. So these will include your community supports. It might be, Hep C programs. It might be withdrawal management services. But you really want that strong network of support and these bi-directional relationships. Ideally, once clients become more stable in your RAAM program, you'd be referring them on to primary care for their ongoing management. The key here is that the RAAM clinic is continually available to support these primary care colleagues. So if your local primary care provider calls you up, says they want some help reassessing an individual, they want some more support, that individual should always be welcomed back into the RAAM. And there's sort of this doors open policy. There is no formal limit to the duration of a client's engagement with the RAAM clinic. However, capacity does remain an issue in many of our sites. So again, just emphasizing the goal of really having these strong primary care connections so that you can refer more stable clients back to primary care so that you have capacity to be accepting new clients. And at this point, I'm going to hand it over to Kristen to discuss identifying a good clinic location.
Okay, you may notice if you look carefully that some people in this picture are also in this room this afternoon. Part of my role here in our presentation today is to do some storytelling about some lessons learned for Stonehenge. As a little bit of background, Stonehenge, we launched the first clinic outside of the MediFi pilot project back in 2017 and have been building our network of RAAM clinics and changing and adapting our network of RAAM clinics since that time. So lots of lessons learned around how to start up a clinic for the topic we're chatting about here. So in terms of identifying clinic location, one of the things we've learned over the years is that the format of the clinic really matters in terms of the population that is in your area, the geography of your area. So for us, for Stonehenge, we are covering urban centers as well as a very large rural area. And we started our very first clinic 2 days a week, co-located in our community health center, our Guelph Community Health Center. And since then have grown to now have a clinic in Fergus, a bricks and mortar clinic in Fergus, which is rurally based, We still have our 3 days a week clinic in Guelph, which is right in the downtown. We launched for a period of time a mobile clinic, which I'll tell you more about later, that was reaching out to the rural areas. And the year before last, launched the Digital Front Door, which is a fully virtual clinic that is now operating 5 days a week, providing RAAM clinic services. And so there's pros and cons of all of these different types of clinic. And I think, wait for it. Yeah, okay. So there are pros and cons of all of these different types of clinics. So for bricks and mortar, for folks where in-person service is really needed, that's a great option. As Katie mentioned, the tenets that are important of all things of clinics are the same that are true for all of ours. They are walk-in or drop-in based. They are low barrier in access. And what we have found over time, oh wait, not yet, just kidding, is that depending on the population, the type of clinic makes a big difference. And so for our virtual clinic, there are some folks where perhaps they live in a rural area that doesn't have great and reliable internet access. That's obviously not a great choice for them. And being able to help with support with transportation or access to our bricks and mortar clinics or a mobile clinic was what worked for those folks. And for lots of folks, we have really found that the Digital Front Door is a great, anonymous, low barrier way to be accessing service. So just to give a little bit of land us in some stats around the growth of our clinics. In 2019-2020, we had 150 people, unique individuals, access the clinics we had at that point in time. Since then, last year in 23-24, we had 1,050 people access our clinics. And of those, approximately half were through the Digital Front Door. So it has really created a significant shift in terms of the amount of service we are able to provide, but also to make sure that people are able to access the types of support and service that they need. So lots of pros and cons for each of these different types of clinic in terms of what works for people and what doesn't. Oh, wait for it. Here we go. Here you will see data from Medify across the entire province in terms of what the different locations are. So the most significant are through hospital, community mental health and addiction services, and primary care clinics. And so this just shows you, as Katie was saying at the beginning, there's a great variety in terms of what clinics look like across the province, and that works in terms of the population and the geography for that area. So here you can see a little bit more detail in terms of the pros and cons of the different 3 types of clinic. So the pros, I think I've gone through lots. If we were going to talk about some of the lessons learned over time, and we've had our clinics in a variety of places. We co-located in withdrawal management at Grand River Hospital for a period of time. We were in a different hospital building that wasn't withdrawal management for a period of time, different family health teams. So we've really tried lots of things to land on where we are right now, and I'm quite sure that will change again, if I'm being honest about that. But in terms of bricks and mortar, obviously cost of rental and accessibility and transportation to the location can be a challenge depending on budget, depending on what that location is and who's needing to access that clinic. I'm going to tell a whole nother story later on about our mobile clinic and the lessons we have learned there. But limited space and limited anonymity are some of the main challenges that we faced in relation to that clinic. And with the Digital Front Door, challenges in terms of there are some parts of service that require in-person. And so needing to make sure we have pathways with local partners or with our own locations that can provide those services. And as I mentioned, for rural populations, the connection to internet can be a challenge. Believe it or not, in this 2024 year world, the world that we live in, it is still a significant challenge for some. So in which case this wouldn't be possible. However, for the most of what we're seeing, it has been the best way for us to be providing support to that population. Okay, I'm going to hand it over to Michael.
Thank you. Okay, so a couple of things also to keep in mind. So When you're starting to launch your RAM clinic, it's important to gain support from the organization leadership and the government as you're rolling it out. So when it comes to the publicly funded RAM clinics, each of the publicly funded RAM clinics in Ontario receive either partial or full funding from Ontario Health. In addition, a lot of organizations either provide some level of funding or in-kind support in order to launch the clinic and the continue running of it. When it comes to costs associated with a RAM clinic, the majority of the costs comes down to your health and human resources. So the majority of our budget at our RAM clinic in Sudbury is completely dedicated to staffing. So to talk a little bit about what we're doing. So I've been asked quite a few times about our hub and spoke model in the Northeast, and I've spoken about it quite significantly. We've changed significantly from when I first started with it, and continue to grow as we go along. Right now we have 16 communities in Northeastern Ontario that are operating RAM clinics. Some of them are operating 5 days a week, like the one in Sudbury. We have a 5-day-a-week RAM clinic, where others are working a half day a week. What this really comes down to is a few things, but one of those is assessing the needs of your community and also balancing that with the resources that you have available. So in some communities, the volume is quite low, so they only require a half day a week. Other communities, there's a huge volume, and they're still only funded for a half day a week, so we spend a lot of time advocating for why those communities need further support and advocacy. Our hub and spoke model, how it works in a nutshell, we have our regional leadership model, which is that center circle there. The regional leadership model is essentially me as the regional lead, and I work very closely with Ontario Health Northeast to provide mainly a lot of data source. So I collect all the data for the region and I share it with Ontario Health. I do analysis and I do a lot of business proposals and advocacy work for the RAM clinics in the Northeast. The other part of it is I work with PHI to help I guess more or less translate all the stuff that you will find in that toolkit into how this will work in different communities throughout the Northeast. It is not cookie cutter, and something that we learned very early on in the launch of this is that what you create for one clinic does not necessarily work in other clinics. So what you need to do is you need to take into the community considerations and wrap the model around the clinic and community, not necessarily the other way around. How this works is we have 4 hub sites, and these are our large hospital organizations or our largest communities in the Northeast. We have Timmins, Sault Ste. Marie, Sudbury, and North Bay. So in addition to being the regional lead, I also lead a hub community. We have hub sites in Parry Sound and in where's our other one? Oh yeah, Espanola. Sorry, forgot. And what we do is provide support to them. Lots more support at the beginning when they're first getting established, first getting launched, first getting started, and then continued support as needed as we go. We also act as paymaster. So when we talk about the funding structure, the hub sites generally are receiving the funding and then essentially funding it out towards those spoke sites. How do we identify which communities need spoke sites? How do we know how many spoke sites our hub area should have? It's constantly growing and changing. And in fact, we are now going to a place where we're going to be reviewing the spoke sites. What we have here took about 7 years to get all these RAM clinics off the ground, and a lot of them are still continuing to grow, and we've identified, I believe, another 7 locations where we feel that RAM clinics are needed, but because of the vast geography of Northeastern Ontario, we feel like we need more of a net approach to this, which is where the digital front door comes in, but as you mentioned, the connectivity is not always great. The last thing I'll say about this is it is a vast region. So the Northeast goes from Parry Sound all the way up to the James Bay coast, across to the border to Quebec, and then back the other way to Wawa and Sault Ste. Marie. So it's a very vast region with lots of little tiny communities in between with different accessibility and different needs. So the importance of working with these communities is essential. So part 2, developing local RAAM clinic programs. As I'm kind of developing the RAAM clinics and as we're kind of leading to change, one of the first things that we always are asked about is identifying policies. And again, it's not cookie cutter. Every community and every RAAM clinic will have different policy requirements. If you're lucky, like we are at HSN, you're a large organization that has like 99% of the policies already developed that you need for your clinic. However, some smaller communities need to develop their own policies and procedures. I think one of the important things to take away from this is really talking about how your processes and policies fit within your organization as well as within your community. So how are you going to be working together with your community partners, partnering programs within your organization, and looking at how the MediFi model fits within that. So some of the ones that are big on here, so should it be drop-ins and booked appointments? Should they occur at the same time? Should they occur at different times? It really depends on your clinic. We've done a little bit of everything. Right now, what we do in Sudbury is we have walk-in clinic 3 days a week, and they are half days, and we have drop-in hours outside of that. So if you come in and our clinicians are available to see you, they'll see you. If they're with appointments, they might not be able to see you. We'll get you connected to the next available appointment or the next walk-in clinic day. Are we doing them at the same time, different times? It really depends on your clinic and your volumes. Different schedules based on clinical role. So some team members can accommodate both booked and fit-in appointments while others can't. Again, it's about balancing the resources that you have and working from there. So this is a breakdown from MediFi based on their recent data about how the clinics are broken up across Ontario. So as you can see here, only about 7% have entirely drop-in hours, whereas the majority of clinics are kind of a blend of different things. Another 5% would be entirely booked appointments. Some have different times for drop-ins and for walk-ins, and then again, 68% fit in walk-in appointments. So in regards to policies in drop-ins, as I mentioned, all clinics in our region are expected to have some level of walk-in support. So whether that means you're walking in and being able to be given an appointment, or you have staff members available to work with people, it really depends on the clinic and the resources that they have available to them. In particular, prescriber hours are very, very limited in the Northeast. We have very few prescribers. So a lot of the smaller clinics have to book time with the prescribers because it's the only way that they can actually get access to them. But they will be seen by a staff member same day in most situations. Will they see a clinician, a provider that same day? It's hit and miss depending on the resources of the clinic. I can speak for HSN. We see people same day, particularly during our walk-in hours. And I would say, and I'm looking over at somebody in the audience who's one of my prescribers, that the majority of the time, if somebody walks in and they are in need of being seen, they will be seen by our prescriber. We will move things around to make sure that they're seen same day. If it can wait, again, we do a level of triage. They may have to be booked an appointment for the next day. They may be able to show up to our walk-in the next day. We also have expectations regionally, and these were set by Ontario Health, and they're really broken down to our funding requirements. But our regional target is the same as MediFi, is that clients will be seen within 3 days of getting a referral or of wanting to be seen and helped for their substance use needs. Some of our clinics are only open a half day a week. So our spoke sites especially, that's what they're funded for. That's what they're able to do from a resource perspective. So it's less realistic for them, but particularly our hub sites, we want to see somebody within 3 days, but as soon as possible is what we aim for. As for our hub sites, it's an expectation that we'll be open 5 days a week. and it's based on community needs and the funding model, and we adjust based on community demand. So again, we spend probably every other week, we have development meetings at our RAAM clinic, and we review our models and see if we're meeting the needs of our community. For the spoke sites, a minimum half-day clinic per week. It's based on perceived need and the funding model. And again, it's adjusted based on actual need and the ongoing request for increased funding. I believe I'm passing it back to you. There you go.
Thank you. Thank you. Okay, so on to another option or on the checklist in terms of how to be setting up a clinic is around identifying supplies, which might sound boring, but is actually an important part of what you're doing when you're thinking about your clinic. So in addition to all of the medical supplies and the different pieces you see here, there are other types of supplies that can be very beneficial to have on site in your clinic. I think the main takeaway message here is that most of the clients or patients who are attending the RAAM clinic are not presenting with just one health issue, and that where it's feasible and where it's possible, we want to be able to support them with those pieces as well and help get them connected to service either through us or through other services in the community, as Kate was referring to earlier. And the more needs that we can meet of folks who come into our clinic, the greater chance that they will return and continue to be accessing service for us. So having some of these other types of supplies and services on site can be really helpful for client engagement as well. Okay, so the next piece would be in terms of staff. And I think what you see here on the slide is that when you're thinking of what staff you want on site, your primary thoughts are around what are the functions. There are some core functions that you need to have within the clinic. And so there are a variety of disciplines that can support that function, depending on your geography, your area, your availability of human resources, the setting in which you're working, what those disciplines are might change. And we certainly see a change in those across the province. Particularly, one of the big decisions for a clinic is in terms of who their prescriber will be and how they will be providing this to the clients within their clinic. So this chart up here describes what you can see in terms of the breakdown of NP, physician, or both across the province. I will say at Stonehenge, we started as physician-led clinics. And over the years, in about 2021, actually, we made the shift to be NP-led clinics, which for us was something we knew we wanted to do pretty quickly, actually, after starting with physician-led. For us, in terms of the structure of our organization, the population accessing our services, what we wanted to build in terms of a team within our RAAM clinics and our setting. And so that we could best meet the needs of the clients accessing our service, we made the shift thanks to some funding, which made that possible in 2021. So we now have a fully NP-led RAAM clinics across all of the different settings that I was chatting with you about earlier. And really the takeaway message here is it depends a lot on your setting. Again, the function that's needed is prescribing, but the discipline might vary quite a bit depending. One of the other things we're really proud of at Stonehenge is our inclusion of peer support in our clinics. So we were the first clinic in Ontario to include a peer support worker in our Guelph clinic back in 2017. And our clinic has had a peer in it ever since. And I can say back in 2017, I saw firsthand what an impact having a peer on our team had. I'll just tell you a quick story. So I was in the clinic. This young woman came in and she was so anxious. It was very evident as soon as she walked in the door. And our counselor went over and was chatting with her, and she sort of checked in and all of a sudden just bolted. It was too much, fled out of the building. And our peer support worker followed her outside, found her, they had a smoke together. And then in about 10 minutes, she came back in and it was in a much more grounded place. Our peer support worker stayed with her, went into the appointment with her, and then she maintained her support and service with us for many months after and got the care that she needed. And I really remember in that moment thinking, I could not have done that. And no one else in this clinic could have done that and brought her back in. So if ever there was a moment I could track back to when I became convinced that Stonehenge needed peer support as part of as many of our teams as possible, it was then in that RAAM clinic. And so We do have peers in all of our clinics. And what that looks like is support within the waiting room. So when people come in, check in, support with them there. It can look like going into the meeting with them if that's helpful. Just helping with that engagement component. Everyone has contact with a peer within our clinic. And I will say we started our digital front door virtual clinic without peers. The platform wasn't facilitating it at the time. And we really noticed that there was a gap in terms of that engagement and support component. So just recently, I think in October, we were able to introduce peer support into the virtual clinic. And I'm getting lots of great reports back from our staff team in terms of the positive impact of that for the clients who are accessing our service. Okay, back to you.
Oh, okay, so let's talk a little bit about implementing the RAAM clinic. And I'm going to talk about two things specifically. First would be establishing care pathways and then launching the clinic. So when you're establishing the care pathways, it's all about relationships. So the idea behind a care pathway is really getting the client from point A to point B. And RAAM clinics, which you're about to see, we get clients coming from all over the place. We get referrals from everywhere. Most importantly, we have high rates of self-referral to the RAAM clinic. But building those relationships and being available for people when they need us for that handoff is very important. And if you saw Katie's presentation this morning, the emergency department is an essential partner within that. So these strong connections and these strong handoffs really help in not only getting the clients into the clinic, which is a big step for a lot of people, but it also helps when we're trying to essentially discharge them from the program. So the RAAM clinics don't necessarily have an end date for how long you're working with people, but the idea is to establish a relationship with a client, stabilize them, and the hope is that you will be transitioning them back to primary care. A lot of that takes trust, and a lot of that takes building of relationships and communication. So when it comes to the clinic processes, you can see real benefit when you have things like shared EMRs between ED and the RAAM hospital, if that's possible. You can have an in-ED RAAM navigator. You can have visiting in-house cultural services such as traditional healers and co-location of RAAM with primary care. So there is no cookie cutter model to RAAM, which I think is a message that we're going to continue to say during this presentation. But having those connections, whether they're internal to your own organization or not, is essential in those care transitions. So here you can see the breakdown from Medify on where the majority of the referrals are coming from. And as you can see on here, which one is it? Over there, self-referral is 31%. So the majority of the clients in this breakdown are coming from self-referral, which is great. They're taking the initiative to come through. Again, the other big ones would be hospital units, emergency department, and primary care provider. So those areas require those essential handoffs. And things that we've been trying within our clinics specifically is building those relationships with our community partners. We are very lucky at HSN to have integrated services. We have a lot of addiction services from inpatient to outpatient. We also have a lot of services such as emergency departments, inpatient environments that we can work very closely with. And because of that, we've established some very key partnerships and key transition moments. One thing that we have been trialing with our virtual front door, as an example, is that connectivity into the actual inpatient environment. So our navigator can work with clients while they're in the hospital still, so that they have an appointment when they're leaving, or at least they know where they're supposed to go. We've trialed all kinds of things like InReach. We've sent our navigators into different environments. We've sent our nurse practitioner into the inpatient environment to do intakes to our programs, to do these warm handoffs. And we've seen real connectivity points through this, which has really helped us establish our clear pathways. A lot of it is negotiation. A lot of it is relationship building, but it's an essential point in building those pathways. The big thing that I think, Katie earlier, I'm going to keep referring to your presentation earlier. So, all the plugs from earlier today. Katie mentioned the importance of the educators. What we did was we presented to the Nurse Clinician Forum, which is the educators in our hospital, and we present to them on a regular basis, but not just them. So we have done huddle tours where we go to individual huddles throughout the building that we work in, but also inpatient environments, the emergency department. We've done multiple so that we try to hit as many staff as we can so that they remember who we are, they know who we are, and they have that warm handoff that we can do. We were lucky enough to have a communication team work with us last year so we could build an ad campaign. We had some billboards up in our community as well. So a lot of it is that communication and getting the word out so that people really know that you exist and that you're there to help. And lastly, it's always about checking and adjusting. We do regular development meetings with my team to see what's working, what's not working. My team is very flexible and they're actually very good because we're constantly throwing things at them, like a new EMR, accreditation, all that stuff. And every time something new comes down the pipe, we need to look at what we're doing and change. Not only that, through COVID, and through the current state of substance use in our communities, we have to think differently about how we're reaching the people that we are wanting to work with. And now I think I hand it back over to you.
Thank you.
There you go.
Okay, so as Michael has reinforced, there's no exact way to operate a RAAM clinic, which should feel freeing, but also to know that Medify is an incredible resource on this front. I think in terms of this toolkit that we are talking about now for setting up clinics, and also the next part of what we will talk about in terms of the targets, as someone, an administrator of clinics, Medify is an incredible resource to give good guidance on what data is collected and how we can be building more consistency across the clinics where it makes sense across the province. So the annual Medify survey is a great benefit, and the RAAM clinic survey, because that helps to give the detail and the context or the data that's in this presentation today, but also really helpful as a clinic administrator to know where we fit in terms of the continuum of clinics across the province. So I'm going to tell you a little bit of a story as promised about our mobile clinic van. So as I mentioned, we offer both urban and rural service. And back in 2022, we determined that we needed to find a new way to be providing services to our rural populations. That we had one clinic in Fergus, but for those of you who are familiar with Wellington County, that's way down here, and there's lots up here that still need support. So we have this really amazing clinic van that has all of what you would need to be having space for a counselor and an NP to be providing service to our clients. And when we had provided service in the county for, I think it was probably about 2 years, over that time we really saw people weren't coming. There was decreasing numbers or sometimes none at all, for reasons that upon reflection make a lot of sense. So one, finding a place to park the van that works and where people are okay with that is a challenge. Also, in small rural communities, anonymity is really important, as it is for all of us in urban centers as well. And it's really obvious what this van is for and why you are walking up to it. And so it was very difficult for folks who wanted that anonymity to be walking up to the van in their very small community to be accessing service. And also, it's cold in Canada in the winter. And that means that staff who are working in the van are in the van with all the doors closed, which is appropriate. But it's very strange to walk up to a van and knock on the door and ask to come in to be accessing service. So it just goes against sort of people's normal nature and the things we are taught as small children not to do. So we determined that we needed to find, and we are still in the process, to be fair, about what to do with the van and how we can best do it. But what you see on the slide here is an example of a time-limited intervention we did with CMHA last summer, where they were having some acute pressures in their downtown Kitchener location with folks around their building who were really needing support, and they were feeling unprepared to know how to best support them. So we brought the van just one day a week downtown Kitchener, parked it right on the sidewalk in front of their building. We got permission from all the bylaw, and everybody was willing to give us some exception to the rules there. And what you can see here is between mid-September and mid-December, how the numbers skyrocketed. And those aren't RAM numbers, just to be clear. We were providing outreach, harm reduction supplies, juice, water, snacks, and all the information about RAM and services that we could connect people to. But this was a good learning for us that the van in our geography is something that works to bring to where we know the people are, rather than parking it and hoping the people will come to us. So we're looking now at how are we going to use the van in this way and figuring out what that might look like. And thankfully for us, the digital front door came into being in and around the same time where we realized we were not serving the rural population well. And it has really, as I mentioned with those stats earlier, really made a big difference. So I think the key takeaway here is that we don't always get it right. But as you just mentioned, sort of that check and adapt is key to figure out how are things changing over time and how can we be using the resources we have to support the population.
So I will close us off here with just a quick summary, really wanting to underscore that there are these main sort of considerations when thinking about setting up your RAM clinic. First, to assess your site's readiness. Second, develop your plan. Third, implement that plan. Go for it. And fourth, always be evaluating, always be checking in, thinking about what is going well, what could be improved, and as Kristen just highlighted, be willing to pivot based on the feedback you're receiving and the feedback from your team and clients. So I just want to share, both Michael and Kristen have kindly shared their email addresses if you'd like to be in touch with either of them for very sort of practical tips and tricks and guidance as you, again, sort of go along this journey of considering whether or not to set up a RAM clinic in your community. My email is at the very bottom there. If you would like some support from the Central Medify team, we're always pleased to hear from you. Please do reach out. And I would like to just make a plug now, again, for some of our resources. Please check out our website, medify.ca. There's a wealth of information there. You can find a number of free educational opportunities that you would all be invited to attend. We do have a number of clinical materials as well, including guidelines and toolkits, which of course includes this most recent toolkit that sort of informed much of this presentation, the RAM Clinic Toolkit. Use the QR code, check it out. We'd love to have your feedback. And I think we have just a couple of minutes perhaps for one or two questions.
I just want to say that QR code is not working
Oh,
at
no.
the moment.
Okay.
But I'm sure that there will be. But everything is on the website if you go to medify.ca.
Yeah.
So if you've been checking and frustrated,
Thanks. Yeah, thanks, Jennifer. Please do use the URL. That will most certainly take you there. I see a question at the back. All right, let me see if we can get to all of that. First of all, let me say I wouldn't say that there was sort of a central sort of intention coming from MetaPHI or anywhere else that we should move specifically towards an NP model. It was, I think, as Kristen highlighted, quite often sort of site-based when they consider what would work well in terms of having sort of a staff prescriber versus a physician prescriber. I'm going to definitely tap on Kristen to speak more to that and why that was the model that suited Stonehenge. As far as physician payments, I would say across the board, most RAM sites that do have physicians, they do bill OHIP for the most part. Some do have a sessional component. There is a section of the toolkit that sort of covers the different options, but certainly by and large, OHIP is the primary source of funding for physicians. I am going to, as I said, tap on Kristen, and then we do have Katie, our NP and nursing educator, who I'm sure would love to speak more about the education.
That was a lot of questions at once, so I'm going to do my very best to answer them for you. But I think for us, what we found is that there is a more flexibility of time and a different scope of practice that NPs are able to do. We were feeling a lot of pressure, as you've just said, in those early days between billings and what we had for sessional fees was not creating something that was sustainable for physicians. In that we had a couple who were so passionate about the work. Dr. Elena Chorney is somewhere at this conference. For those of you who know her, thanks to her, we were able to launch our clinics. But from a financial perspective, it wasn't feasible. And so it was, and we wanted to build more of an integrated team-based care, which was difficult to do with physicians who are coming in just for the RAM clinic days, and we had limited days at those times. Our setting has changed a lot. We have multiple clinics every day of the week now, so that looks a lot different. But primarily because that meant we could properly compensate the prescriber and have them be present for more time and integrated as part of our team. And it also allowed us to have more days a week of clinic available for our clients. And I'm going to pass it to Katie to best answer your question about the education.
Hi, happy to, but want to acknowledge that every province is different in terms of nurse practitioner education and qualifications. Unfortunately, across Canada, Ontario was very lucky that the nurse practitioners much earlier on than other provinces had the full ability to prescribe all of the substances as long as they completed a narcotic prescribing course, which most complete as soon as their graduation occurs. You can dive into this field, and it's actually one of our goals to make sure that everybody that's prescribing knows that this is not a specialty field. This is what we want everyone in primary care and elsewhere to be taking on as well. So it didn't feel like a reach at all for nurse practitioners to come into the field. For Stonehenge specifically, the requirements for education for any clinician, especially the prescribers that are coming on, we have a hefty list of training requirements. They get options between which they'd like to choose, but there are many, I love free things. There are many free education courses that are available from BCCSU, from CAMH, from MetaPHI, from Mac Health. There are so many that are available to get people up to speed with what they need to know. I do love BC's version of the fellowship and addiction training that exists that's not here in Ontario. So I could see where it would be a requirement in other areas, but it just never had to be here, and it's been functioning really well. Maybe just because of time, we'll take one more question before we move on. If you do have extra questions, hang out because the presenters will still be here. Some of them are still presenting. You have a very eager hand. Would you like to go ahead?
Yeah, a bit of a complicated question and answer. I say no. There is no sort of protection around the term RAM, uh, which is why we sort of consistently say publicly funded RAM. There are, I think, a number of settings that use the RAM term just because it's sort of easy to grasp. It kind of infers low barrier, and it's not a protected term, so they're welcome to use that. even the sort of funded RAMs, as you've heard, there's not necessarily consistency across the board, and that's largely because we do not have standards, because there's so much variability in resourcing, and it's quite impossible to set requirements and sort of set expectations when not all sites have access to the same, again, health and human resources. They don't have access to the same sort of budgets. And so I think the best that we can do is set the quality targets that MetaPHI has created. And thankfully, is the very next talk. They're waiting to come on board, and they will certainly do a deep dive into the quality targets that MetaPHI has set and are intended to really help sites think about how they can offer the best quality of care that they can with the resources that they have available. Sorry, not a totally, I'm sure, satisfying answer, but I'm hoping that this next talk will sort of give that deep dive and more information that you're seeking. Before I get off the stage and hand it over to the rest of my team, I just also wanted to mention the annual report that was referred to several times throughout this presentation. That is based on this annual survey, and the report will be actually available in the coming weeks. I know we have many sort of RAAM administrative leads in the audience right now, so you will actually be seeing that report. It'll be arriving in your inboxes most certainly before the new year. It should be just in the next few weeks, so keep your eyes out for that. So thank you so much, everyone, and I will hand it over to the next group.
Okay, quick plug as we're transitioning. Thanks for everyone that came. There are resources. Speaking of QR codes that don't work, apologies for that. The links do work, but also this table up front, if you are willing to leave your chair, has tons of our printed materials if you wanted samples or to see what it kind of looks like. They are to take and go. Gosh, we have a ton you'd have to go and explore. So please feel free during the presentations. No one will be offended. That's more than okay. And for the question about the clinics, I'll just say you're not alone. There are obviously clinics that do amazing and some clinics that we would like to do better, and they want to, typically funding kind of considerations, which brings us to our quality targets. We're not on the right slide deck. Or can we keep going? Is it click through? No, sorry. That's okay. Maybe I'll do the introductions while we're doing this, if that's okay. So our next group of speakers is going to be starting with Sarah Clark. Sarah has been a part of the MetaPHI program since it began in 2000. Sarah's going to help out because this is what Sarah does for our program. So she's been a part of the program since 2015, really when it began. She works with people with personal and or professional expertise in substance use to collaboratively develop educational materials and resources for healthcare providers with the goal of ensuring that people who use substances receive high quality care. Sarah has a PhD in the social sciences and is currently a master's student in health system research. She also does everything. Everything and then some with our team. So very grateful for Sarah. Kristen, I think, okay, we're going to do a quick promo of Kristen. So Kristen Kerr is my boss and CEO of Stonehenge Therapeutic Community. I have a nice intro that you probably heard the first time around. It's all brilliantly true, and I should be intimidated to have all of my bosses and managers and everyone staring at me. But a fantastic human being, a fantastic leader, and a true advocate for the work that she does in trying to promote care for the region, which I think comes through in the stories that she easily tells. So excited to have you for the next presentation too. Dr. Jennifer Wyman, perfect, thank you, who accidentally waved, is currently an assistant professor in the Department of Family and Community Medicine at the University of Toronto, medical director of the Substance Use Services at Women's College Hospital in Toronto, and clinical programs lead with MetaPHI. Her work centers the experiences of people with lived and living experience of substance use in education, research, and guideline development. She has led the development of several of the guidelines on opioid agonist therapy, as well as tools to support implementation for addiction care in emergency departments and in primary care settings. She is involved in evaluating the impact of change in care on the outcomes and experience of people with opioid use disorder. So I will let them take over. We do our presentation on quality targets. Thank you. And please do come up and help yourself if you'd like. The quality targets are printed and available for people to grab and flip through. Thank you.
Well, advance, and that goes back if you go too far, so to the right is forward.
Okay, awesome. Thank you for the introductions. Thank you for being here. I think most of you were here for part one, and this is really what do we do, right? Once you've sort of started your RAM, you've gotten yourselves together. What does it mean to try to work on sort of the RAM model, the ideal, and working towards that? None of us have any disclosures. We already talked about this. We're going to talk about what are the quality targets and use some examples around what that looks like. And I can't see anything on here. I'm really sorry. So sorry for my turning. So why did quality targets matter? An intro and the provincial picture, and then some of our specific examples. So that's you, Sarah, right? Thanks. Gina, this change so you can see on here?
Oh, no, it's okay.
Okay.
Yeah, I'm good. Thanks. Hi, everybody. My name's Sarah. I am the Menify Knowledge Broker. I'm very happy to be here and see everybody. So thank you all for coming. So in the previous talk, we heard a lot about the practical aspects of setting up a RAM clinic. And obviously there are a ton of logistic matters to take care of when you're getting a new service up and running. And the RAM Clinic toolkit that Kate mentioned is a really, really helpful resource. It's so comprehensive. It was an enormous amount of work that Kate and that team did. And it's a really helpful resource that outlines the considerations that you need to keep in mind during the development of any service. What we're going to be talking about in this presentation is the importance of setting the clinic up in a way that facilitates the provision of high quality care right from the start. And the framework that we're going to be using to talk about this is the Medify RAM Clinic Quality Targets document, which, as Katie said, is over there. We're using the term targets here very deliberately because what we're talking about is things to strive for and aim for. So what is the point of having targets for care? So first of all, clarity of direction. Again, we're talking about things to strive for, and having quality targets that everyone on the team is striving to meet gives you all a clear direction to move in. Next, quality of care. So having quality targets allows the team to consistently work towards providing high quality care to the people that you're serving. And finally, consistency of care. Shared targets create shared expectations. And this means that the care that people receive is not dependent on which care provider they happen to see. So everyone is kind of on the same page, and the care that's being delivered is more consistent. So the purpose of having quality targets for care is to make the care experience better for everyone involved, and that includes the administrators, the clinicians, and the clients. Yes, so as I said, the framework that we're using to talk about quality care is the Medify RAM Clinic Quality Targets, which is a document that we first developed. The first iteration was in 2022. With the context that Medify had been recently tasked by the Ontario Ministry of Health to provide support to the province's publicly funded RAM clinics, the purpose of this document was to set out our vision of ideal RAM clinic care in order to make care, again, more consistent across the province, define the quality indicators that let RAM clinics assess their own performance and identify any areas that they need for improvement, and to inform the questions that we ask in the annual survey of RAM clinics, which Kate mentioned previously. Crucially, and I do like to emphasize this, the purpose of the targets document is not to punish, not to rank RAM clinics, not to scold anybody or call anybody out. We chose the word targets very deliberately. These are aspirational goals, and not meeting a target is not interpreted as a failure. It sort of shines a light on areas that need improvement or where support is needed, I should say. The original document was created by our Medify team and input from I think it was 16 people on our advisory committee at that time, plus some community consultants with personal experience of RAM clinic care, and the Ganawish-Kadawe Centre for Wise Practices, which is a hub for Indigenous health housed at Women's College Hospital in Toronto. We revised it earlier this year by a small working group of RAAM clinicians, administrators, and clients, and that group did include both Jennifer and Kristen. So that is the current version, is from early 2024. The document uses a framework of 5 overarching goals of quality healthcare. The team developed 14 RAAM clinic specific quality targets that all connect to those goals, and each target has a set of indicators that measure progress towards those goals. Towards those targets. The healthcare goals, which come from the Canadian Quality and Patient Safety Framework for Health Services, are people-centered care, safe care, accessible care, appropriate care, and integrated care. And each of the quality targets we developed is connected to at least one of these overarching healthcare goals, often several. I don't want to spend too much time going through the targets since there's copies there. They're on our website. I will go through them quite quickly, just to give you an idea of what we're talking about. So first, access to services timely. This is about ensuring that the RAAM clinic has drop-in hours that are sufficient to give people rapid access to care. Next, an appropriate range of services is available, and this is about ensuring that service users have access to pharmacotherapy, psychosocial support, peer support, harm reduction supports at the RAAM clinic. Next, flexible care delivery options are available. This refers to the availability of different methods of service delivery: in person, mobile, phone, virtual. Care addresses the spectrum of substance use. This means that a wide range of substance-related concerns and goals can be supported by the care team. Care is personalized to the service user. So this means that the team provides care that is collaborative, people-centered, tailored to each individual's goals, preferences, and circumstances. The care is culturally safe, meaning that the clinic team is supported to provide care that recognizes the importance of cultural practices as elements of care. Care is trauma-informed, meaning, again, that the clinic team is supported to be aware of the pervasiveness of trauma among people who experience challenges with substance use, and to provide care that promotes safety as much as possible. Treatment or referral for concurrent health needs is provided, so there's a plan within the clinic for how to manage the other health needs that a person comes to the clinic with. The clinic actively supports continuity of care. This means that there are mechanisms in place that reduce barriers to people initiating and continuing their care. Sorry, I'm almost done, I promise. The clinic has processes for facilitating collaborative care with local services, including bidirectional referral pathways. This means building up connections within a local network of services to facilitate access to service users and making referrals work as smoothly as possible for clients and for the clinicians. The clinic keeps data regarding visits and discharge to inform understanding of clinic flow. So clinics keep track of visits and of service user dispensation, where they get sent to, and this data is used to identify areas for improvement in service delivery. The clinic collects data on service user experience to inform quality improvement processes. So this is about getting feedback directly from the people who are using the service in order to identify what's working and what's not working for the people who are coming through the doors or logging in or whatever. Clinicians provide consultations and support to clinicians at other services. This might mean shared care or other types of formal and informal consultations on substance use. And finally, clinicians provide education to local service providers and agencies in order to build capacity. This might mean presentations or shadowing opportunities or other things that develop skills and build capacity for substance use management in other services. I would like to acknowledge that this is a lot of stuff, and again, targets, crucially. But if the service is designed with these things in mind, if this is sort of at something that people are thinking of from the get-go, it helps a lot with expectation setting and with creating internal processes that facilitate some of these things as much as possible. So what does provincial progress towards these targets look like? We mentioned the annual survey that Medify carries out of the publicly funded RAM clinics. And this allows us to get some insight, not, obviously there is a lot going on across the province, but it allows us to get some insight into where things are going well for the clinics and where additional support might be needed or be beneficial. We sent out the 2024 survey in May. Our final report is almost finished. I swear, I'm almost done. We received responses from 81 publicly funded RAM clinics. It won't surprise you to hear that the responses vary a lot. But I do want to give some examples of some trends that we noticed just in going through the survey results. So there are some consistent hits, some things that are going well across the province, some things that are a little more hit and miss, and some things that seem to be challenging sort of across the board. A couple of things that are consistently going really well, making multiple methods of service delivery available, and this is in line with Target 3, which is about flexible care delivery options. And Kristen and Mike were both talking about this, having a bricks and mortar care, having mobile care going out into the community, the digital front door, and other virtual services. So that is going quite well across the board. Sites are also providing support for a variety of substance concerns. So not just opioid use, but also alcohol, stimulants, benzodiazepines, and cannabis. And this is in line with target number 4, which was the one about care that addresses the spectrum of substance use. And sites are providing consultations and shadowing opportunities to other clinicians. And this is in line with targets 13 and 14, which are about developing capacity in other sectors. Some with a bit more variation. One, and this will not surprise anyone, there's a lot of variation within the province in terms of how many weekly drop-in hours are available, which relates to Target 1, which is about timely access to care. And there are, many different reasons for this, and the sort of number one reason is resources. Sites have different access to funding and different access to clinicians. Some clinics just do not have the staff or the funds to offer a lot of drop-in hours. Data tracking is also really variable, which relates to Target 11, just about collecting data internally. And again, this is partly a resource question. So sites use different EMRs. Some sites use many EMRs. One site reported having to use 4 different tracking systems within a single clinic, which blew my mind. And of course, this affects how easy it is to track and retrieve this type of data, and to share data, to share information about clients within a single service. It was just, yeah. I got upset and I lost my place. Here we are. Some sites collect feedback from service users and some don't. And this relates to Target 12 about input from the people using the service. And again, this is a resource issue. Some sites there are processes and mechanisms. You need staff to collect that data, to analyze that data, to do implementation about making changes. Some sites just do not have what they would need in order to be able to do that. And then finally, there were a few targets that seem harder to hit across the province, and they were all mentioned in the previous presentation, which I wasn't expecting, which is interesting. And you'll also hear from them, from Jennifer and Kristen, when they start talking very soon, I promise. One of the things that really stood out is a general lack of availability of peer support, which is part of Target 2 about the range of services offered. So we heard from Kristen about what a difference that makes for clients. You'll hear more about it from both Kristen and Jennifer, but it's something that not many sites are able to offer currently. Another challenge is about having all RAM clinic services available during all drop-in hours. And Michael mentioned this issue in the Northeast, that you might have lots of staff. Prescribers are available in a much more limited way. And then finally, harm reduction supplies are not, some harm reduction supplies are not widely available, notably injection and inhalation kits, which again is important for life-saving, but Kristen also made the point in the last presentation that they promote engagement with clients. So having them is an important thing, and they're not super available right now. And my intention here is not to suggest that clinics are doing a bad job by not providing these, not having these supports available, not meeting these targets. Not meeting a target indicates that support is needed, and that's part of our role at Medify, is to find these areas where support is needed, where something might be needed, and to help as much as we can. So with that background, I will pass it over to Kristen to speak about Stonehenge some more.
I'm back. So I'm not going to tell you more about Stonehenge specifically because I feel like we covered that pretty well in the previous hour. But I am, so last presentation I talked with you with a bit more of a story about our mobile clinic. And now I'm going to give you a story about one of our bricks and mortar clinics and our digital front door, just to help land for us where, for you in terms of where these targets have made an impact for us and where we're seeing such a positive impact for the people that we serve. So our very first RAAM clinic back in 2017 launched out of the basement of the Guelph Community Health Center. It was half a day a week to start, as we began it without any funding from the government. It was before RAAMs became a known as they are now. And now it has expanded to this point. It expanded to first a day, then 2 days, then 3 days. And where we are now is that we are located on the main floor of the Guelph Community Health Center in a space that was co-designed specifically for our RAAM clinic. It operates 3 days a week out of this site. And this Guelph Community Health Center serves the Tier 4-5 population quite significantly. They have a low barrier health hub that is also on this main level. Right now they have a consumption and treatment site. They will not in a few months, but that is there currently. And have had alternate prescribing on site. Most recently, in this picture in the bottom, they've introduced a pharmacy that can support in terms of injections and prescriptions that are coming from the RAAM clinic. So over the years, we have co-developed with the Guelph Community Health Center a health hub, a low barrier health hub that incorporates our RAAM services. And we've seen a significant impact positively for the people who are accessing our clinic because they have all sorts of things in one place that are what they need. And when they are ready and interested in making a change in terms of accessing a new or different service, it's probably there on site, or the people are there on site who can get them to where they need to be. So for us, co-location, the target here is around co-location, and for us, which 3, 8, 9, and 10, for those of you who have your cheat sheets with you, this example is meeting those. Co-location has made a significant difference for the people who are accessing our clinic, but also for the folks who work in our clinic, because they feel they have more supports around them in terms of what the clients are presenting with their need is outside of what our clinic can do. They know people across the hall who they can connect them to be able to do that. So the co-location is great. We also co-locate with a family health team in Fergus, which is a much different experience in terms of what's on site and what's available there. So just where you are co-locating really makes a big difference. And for us with the CHC has been a real game changer. We've already chatted between Michael and I, we've chatted with you a fair bit about the digital front door. I want to properly give some acknowledgement to the Royal Hospital in Ottawa who came up with this brainchild in the first place and has helped to expand it across the province with I think it's 8 organizations somewhere in there who are connected with it. I've talked to you already about why it works in terms of the rural populations, but also for urban populations as well, and for anonymity. One of the things that has started to happen across our programs that we didn't necessarily anticipate is how access to the digital front door is supporting our staff and our clients in programs unrelated to the RAAM. So for example, we have peers who work in the emergency departments at our local hospital, so one peer per hospital. And they're supporting individuals in the emergency department who are presenting with poisoning, and their loved ones who are there to support them. And what has started to happen is that our peer has a tablet, and right there in their bedside, when they're ready, they're giving them the tablet and connecting them to the digital front door while they're still there in the emergency department, who can then connect them with the supports outside when they're being discharged. And that's beginning to happen in more of our programs as well. So for us, this digital platform is making a big difference in terms of our network of RAM clinics, but also broadly across our continuum of services in terms of who's able to access these programs. As I mentioned, also, we recently added the peer back into the digital front door, not back, but to, it has not been there yet, which has been a really big change for us. So main takeaway here, in addition to what I've shared already about the digital front door, is just options for access that might be through other pathways, through other services. There's some distinct advantage we're beginning to see along that front. Over to you, Jennifer.
Okay, thank you. So I am working in a very different setting, just to set the context. So I'm the medical director of the substance use service and the RAAM at Women's College Hospital, which is in downtown Toronto, not on a very high traffic area. So you could say it's not sort of the most accessible in terms of people passing by. It's sitting within a hospital, so there are obviously issues. Someone has to kind of walk into a hospital and find us. And we share a corridor with another clinic. Like, it looks just like a hospital clinic. So I think it's nice in that way. There's nothing that sort of calls out substance use, or it's very clean, it's very clinical, but you have to find your way there. And then just in terms of some of the other things we were talking about with respect to how our service is managed, our substance use service has booked appointments Monday to Friday, all day. The RAAM drop-in hours are structured as 10 to 1, Monday, Tuesday, Thursday. We have added some extra afternoon for digital front door that you keep hearing about. We will see people if they come in outside of those hours. But you could say that those are not sort of the greatest hours overall in terms of the number of hours or the times of day. And I just want to say that everything that I'm presenting, everything actually that I do at Women's is really built on the work of Mel Cahan, who was here this morning, if anyone was in that presentation, who really established the substance use service and the RAAM at Women's College. So I'm very privileged to be, expanding on the work that's there and trying to figure out how it is that we make it better. So for me, I'm wearing two hats, because I'm wearing the Women's College Medical Director hat, and then I'm wearing the Medify hat, thinking about designing these quality targets and how do I make sure that I am, sort of living and implementing these things that I'm advocating. So I'm going to talk about 3 projects that we've worked with. One is the RAAM clinic evaluation, one is peer support, and then the third just really briefly about data collection, because those were all things that I felt that we were not doing the best job at. I thought we had a great team providing really high quality care to people who came in. We could address any sort of type of substance use issue in terms of OAT, alcohol, stimulants, with both medication and with psychosocial support from that first visit. But we really didn't know how well we were doing in terms of trauma-informed or culturally appropriate care, how safe people felt, how accessible they were. And so we wanted to start with a RAAM clinic evaluation to see how we were doing in terms of meeting those targets. And we formed an evaluation committee that included people with experience of being RAAM clients throughout the process. So first we had to sort of develop a little project committee. Because we're in a hospital, there are steps you have to go through for everything. And so, we first had to go through a process of figuring out how we recruited the project advisors and getting approvals for that. We were very fortunate, though, that there is a research program at Women's, and we had a little bit of money left over from another project that we could direct towards getting some research support. And then we had a summer student to help with actually sort of running the evaluation over the summer. And we were very intentional in terms of setting the stage for how we were going to plan this work together. And we wanted to make sure that everyone understood kind of the role. We took some of this language from some of the work that Medify has done, working with people with lived experience on our targets document, what we've called terms of reference, although that sounds a little bit formal, but wanting to make sure that it was really clear what the rules of engagement were and how we valued lived expertise along with the so-called clinical or professional expertise. So together we decided how we were going to design the evaluation and what the processes were. And we decided to do a two-part evaluation. First, using a survey and then client interviews. So for anyone who's thinking about doing this kind of evaluation or QI, just good to know that there actually, at least in Ontario, is this tool called the OPOC, the Ontario Perception of Care for Mental Health and Addictions. I had worked in this field for a long time and I never knew that this tool existed. So there was a lot that I learned through this process. What's great about it is that it's an online survey. It's run through CAMH. Any organization can utilize it for free. Of course, you have to have, again, an agreement between your organization and CAMH, which is another set of steps. But you can't modify it. You can ask the questions as they are. It's a standard survey. It's, just a scale. There's no room for feedback at all. So it's easy for people to access, but the quality of the data is really limited. And we wanted to get, to dig in more into learning about people's experiences. So we designed a client interview that was ultimately conducted by our summer student. And we wanted to use this accessibility framework called the Levesque framework, and designed questions. Again, our project team, which included people with lived experience, to make sure that the questions were really worded in ways that would land properly. So I'm sorry that it's hard to see these slides up here. It was really gratifying to get lots of good feedback on how welcome people felt. And that it was, being part of the RAAM was really a step for them on their recovery journey. Everybody thought that we should be promoting the RAAM, that people should know more about it. But we did get lots of comments about the fact that the hours were limited, they weren't ideal. The check-in process could be clearer. Which gate or desk people went to was a little bit confusing. And that sometimes if they saw multiple providers, that was confusing to them, especially if they saw a learner, which we often have in our clinic, an addiction service worker and a physician, that the plan may have changed from what they thought. And so there was some feedback around ways to make that clearer, like looping back at the end. So we took all of this data, we presented it to our team, and came up with some recommendations around adjusting the check-in process and thinking about how to expand our hours. That's not so easy. Again, working in an organization and even aside from the organizational rules, just people who get really sort of set in a particular way of doing things can make things a little bit hard to change. But we committed to doing this on an ongoing basis. We committed to including more people with experience in terms of advising our projects. And the questions that we used are available. So if anyone else wants to do their own evaluation, that can be a template if that's helpful. I do want to say that the core questions about were we, providing culturally safe care, were there barriers, or were people from all kinds of groups accessing our service, we couldn't really answer. Because in the small number of people, so again, great idea, but very hard to implement in terms of getting people to agree to a 45-minute interview, even with an honorarium. I think we had 11, if I remember correctly, sort of 9 completed, and no one self-identified as being from a marginalized group in terms of being Black, Indigenous, not having, I think one person did not have English as a first language. And we just had incomplete data with respect to gender identity or sexual orientation. So everyone who answered the survey had positive things to say, but we know that there's still a lot of work to do in terms of ongoing work in terms of this process. In terms of just thinking about QI, as I've said, it's a great idea for us all to be wanting to do QI projects, but they take time and effort and money. It can be hard to keep up the momentum. Not all organizations have that sort of knowledge around QI built in, but there are some great resources that are part of what was HQO and now Ontario Health that are still online there, and courses. And so we haven't given up. We're going to keep doing this, and we're actually involved in a project now looking at enhancing contraception screening and family planning within the substance use service. So that's QI project number 2 for us. The second project that I want to talk about is peer support. Something that we had talked about for a long time at Women's, and sort of kept talking about but not being able to actualize. And I know that for the people in this room, I don't have to explain the value of peer support. Lots of things that we had to think about. I actually thought that this was the slide. Okay, just reversed. So where do you get money for peer support, right? If you don't have it, every organization is sort of maxed. I'm amazed at hearing about all the peer support that Kristen has at Stonehenge. So funding is a huge one. For us, we were able to get some funding to do a pilot through the Women's College Hospital Foundation. So that's charitable dollars. Those are not dollars that you can use for long-term salaries, right? So this had to be run as a pilot, and obviously part of that pilot means that we have to be looking for sustainability down the road. Women's College had no experience with peer support, so there was a lot of hesitation. What does a peer actually do? Oh my God, could those people have criminal records? Who's going to mentor them? What about their job description? What if they relapse? What if they use while they're like all kinds of questions? And we recognized that we didn't really have all of the answers because we didn't have that experience as a small kind of division within the hospital. So as we thought about those things and developing the role description, looking to other partners, we realized that for us it would make a lot more sense to work in partnership. And so we partnered with the Craftsman Center, which has lots of experience in terms of training and supporting peers, including in other hospital settings, which was important for us and for our hospital to feel comfortable in terms of that partnership. We really had to think about getting our team ready to understand what are the expectations, what's the role of a peer supporter, what's kind of in scope and out of scope. Thinking about access to EMR, again, in our hospital setting, they're thinking, oh, the peer can't see EMR, that's confidential information. Are there different kinds of categories of things that they can see? Where are they going to meet people? And we really had to think about the flow of people coming into clinic, how we would evaluate the peer program, which is a big project in and of itself, and as I said, thinking about sustainability. But having said all of that, it has been hugely worthwhile. We are so, so grateful to have Walker, who's standing beside me in that picture. We had a first peer with us for 6 months, hired through Craftsman, and then a little bit of a window. We have Walker, and then the other people standing there are Janice, who's our NP, who is sitting in the back of this room, Rebecca, who's our clinical manager, who has been a huge ally and support, and obviously that makes just a massive difference, and Camille and Alan are addiction support workers or counselors. There are a whole bunch of other physicians who aren't in this picture who all work part-time in our clinic. We also have a part-time social worker and a psychiatrist for 2 half days for consultation. So I can't say enough about how impactful it's been to have a peer supporter working with us, first Jordan and now Walker. One of the quotes that you couldn't read likely on the slide from the evaluation was that, I want to be like, that's my goal, right? I want to be the peer as I get better and stronger in my recovery. Walker and the program were featured in a little kind of strategic communication thing. And Walker's learned a lot too from working in our setting as opposed to in the other kind of WMS settings where she's been before. So lastly, data collection. That's one of those targets that we were not doing very well on. And how do you know what you're doing or what you need if you don't have a way of keeping track of where your service users are coming from and where they're going? What we had in the past was really just kind of the numbers that basic, decision support at the hospital could use for new or repeat clients, visits, and the discharge diagnoses. I should say again, we're working in a hospital setting. We do have Epic. There are good and bad things about having it, but we got to figure out with some of the data support people what we wanted to do. And what we learned was that, you could put all the information you want in a note, but that information is not accessible because you can't pull the diagnoses or the plans or any of those kinds of things from a note, no matter how good the note is. So what we did is we worked with the EPIC team to develop flow sheets. And the idea of a flow sheet, obviously familiar to everybody, is that within EPIC there are these drop-down options. And so we created questions with drop-down options that then could be pulled so that we could see, for example, how many days it took for someone to get an appointment or get to the RAAM, forget about appointment, the whole idea is no appointment, get to RAAM from the time that they first wanted to. Where were they coming from? Who did they hear about RAAM from? Was it Emerge, family for physician? What were the kinds of other sources? We could gather more information about their substance use, etc. It's not the most user-friendly system, I have to say, and it sort of reflects one particular flow in terms of people coming in, being seen first by our addiction support workers and then by a clinician. But at least we can now figure out where people are coming from, how long it's taken them to come, what the substance use is. So if there are multiple substances, we can capture that rather than one discharge diagnostic criteria, which was pretty inaccurate. And we can identify where they're going. So have they been referred to our withdrawal management or AACU that we use, or some other withdrawal management setting, other community organizations, psychiatry, back to primary care, etc. And so using that and then using the sort of general data support, we now are looking at quarterly scorecards where we can see how many people are coming, new, follow-up, our appointments where people don't attend for whatever reason, and what the overall substances are. So is this a me slide wrapping up?
I think it's me.
Over to Kristen.
Okay. I specifically asked to have this wrap-up slide because I wanted to take a minute to really rave about Medify, and I don't work for them, so therefore it seems okay, like not self-promotion. I think as an administrator, there are some distinct advantages to being connected with and receiving the supports from that we've learned about today across both of these presentations. Number one, it really helps with advocacy external to the organization, advocacy around funding, advocacy around what services are needed, connecting with other services in the community. These targets from Medify have been significantly helpful for Stonehenge in relation to that. Also, helps to facilitate internal conversations about what's needed within our program. So what should we be doing? What shouldn't we be doing? What should we be striving more for? We have seen that. In terms of the clinic day-to-day, what I hear from the team there is that once a month we pick a target from the list and we assess how we're doing against it to help us know where are we going and how can we be improving as an ongoing quality measure for our program. So I think if you aren't connected with Medify, either if you are involved in a clinic, or for those of you who are tangentially involved with the clinic, that connection to Medify is really valuable both internally and externally to your clinic and to your organization. So I really want to strongly encourage you to do that. I think hopefully, as you have learned from our presentations today, there are many, many resources on that table and on the website that Medify can support with. And I think we're time for some questions. Yep. Time for some questions, and thanks everybody.
Thank you so much. And Kate and Michael, I'll flag you as well because there were some from this morning, so be prepared to jump up if you need to. I apologize, I missed you earlier. Would you like to go first? Thank you. Yeah, so the question is about psychosocial supports, what they look like in practice. Thanks, Sarah, for coming up. And what they mean for a clinic that's not supposed to be potentially someone's forever home. Sarah?
Thanks for the question. The short answer, I think, is that we don't have a good sense of exactly what is being done. The types of things that we recommend are brief interventions, because exactly to that point, that it's not intended. I mean, often, and I think it should be said that often people do end up sticking around in the RAAM clinic for a long time for many reasons. A lack of primary care in their area, many reasons. I think there are different techniques from different therapeutic traditions, like CBT techniques, DBT techniques, I think are pretty commonly used, and those are the ones that we sort of talk about. Motivational interviewing, of course, I should have mentioned. These are the types of things that we hear, or my experience at least, and I would invite everyone else to weigh in, that we hear about people doing and that we get requests for training in. Motivational interviewing comes up a lot as something that people want training in. The psychosocial care is delivered by a lot of different types of practitioners as well. There are social workers, counselors, peer support workers, physicians, nurse practitioners, nurses, and whoever I forgot to mention, I'm so sorry, are all delivering, I think there's a lot of that type of care being delivered by different practitioners doing different things. I don't think that's a super satisfying answer, but yes, Jennifer's going to say a bunch of stuff.
Well, I can just speak to our setting, but I think, you've heard that there are so many different models in different places that relate to different resources. And sometimes I'm blown away when I hear about what people are doing. I think this probably goes without saying, but the reason to really highlight psychosocial support is not everybody wants medication, right? And so people should have access to the kind of support they want. And not everybody who wants medication wants to engage in other kinds of counseling. But at least in our setting, what happens is that if someone comes into the RAAM at that first visit, they see not only someone who can prescribe, but also someone who is a counselor kind of person. We call them addiction service or addiction support workers. They are not social workers or therapists, but they've got lots of training, different kinds of training overall. And people also can meet our peer worker. They don't have to meet the peer worker. And then everyone is offered the opportunity to continue those meetings if they want to. And lots of people do. And sometimes people don't, and then they sort of go away and then might come back to it later. Again, as I said, because our RAAM is kind of part of our larger service, we have some other things that we can offer in terms of social work with a huge waiting list for CBT. Groups once or twice a year, like Seeking Safety, and now a contingency management program oriented towards people who use stimulants, and that's new, and also kind of getting up and going. So I think from what I know about RAAMs in different settings, those are some of the different modalities that they're doing. I think, the idea of doing long-term therapy doesn't really fit. And so again, a lot is really oriented around connecting people to community resources where they can get other types of counseling, connecting people if they need other kinds of day programs or residential treatment. Yeah.
You can grab the next one. I also missed you earlier. I'm sorry. Go for it.
So I'm super familiar with OET, not so familiar with RAAM. If you can just give me, what's the difference between an OET clinic and a RAAM clinic? So, and then another question.
Please, yeah. Okay, so the question for those that couldn't hear it is RAAM model versus other models for addiction medicine, maybe in Ontario, maybe across Canada, and then comparisons between them, kind of. So who in our group of speakers wants to tackle it?
Well, anyone else in our group, feel free to join me. I would say that, a key component is that RAMs treat all substances. So not only opioids. And having worked in various OAT clinics, I think the focus was very specifically on opioids and wasn't even really inclusive of other substance use care for people who were on OAT. So someone can come to RAM and regardless of the substance, they're going to get care. The other thing is that there is this emphasis on it being not only about medication. I don't want to, like, wraparound supports is a little bit too strong, right? Some RAMs are connected to primary care and provide those services or housing and referrals and different things. Others are much more limited in their scope. But I think overall, in terms of the way RAMs run and the targets, is much more of an emphasis on thinking about the elements of care in addition to a prescription that make things work for someone. So everything from filling out forms, right? ODSP, OW, special diet forms, referrals to other community agencies, making other kinds of referrals, whether it's for mental health or for physical health. And, I know that there's a big range of OAT clinics in the province, but my experience is that many are not providing those more comprehensive services. So I think those would be key elements. Kate. No, it's good. Yeah. Yeah, funding differences is a really key thing too. So OAT clinics, again, by and large, I want to say physician run, working on a fee for service model. And I understand that that's one of the reasons that providing those additional services can be limited. Whereas we're talking about publicly funded RAMs. I know that that was a little bit of a discussion earlier, but the publicly funded RAMs have a mix of funding that tends to support some of the infrastructure and some of the allied health that allows for supporting NPs, nurses, and other kinds of counselors, which helps to support those other services. What else did you want me to say about the funding? Okay. So, yeah, I think OAT clinics can be low barrier in terms of not requiring appointments and having flexible hours and having virtual as well as in-person care. But I think I've already spoken to what I think are some of the differences. Yeah. Oh, I think that's a great topic. We should certainly talk about what that could look like and how to do that, because that's challenging, but I think would be really critical to being able to actually establish that we're doing what we think we're doing, right? There are some evaluations that I think were mentioned earlier that RAM care has been shown to reduce emergency department revisit rates and admissions within 30 and 90 days for people who come with both alcohol and opioid use. I don't know that data exists for other models, but yeah, we should keep looking at it for sure. 1, 2, yeah.
Sorry.
Oh, yep. I'm going to defer that to Kate. I guess the question is what kind of support. Certainly, we have done presentations. We've shared materials with Katie in Newfoundland, out east, and other places. So, yes. Okay. The short answer is yes. The long answer is how do we do that? Sure. Yes, please. Yeah, JP.
I think my question is more for Kristen and Michael here. I started working in RAM in 2017 as well, and it's so inspiring to see all the things that you guys have done with that model since back then. I haven't worked in one for 5 years, but you guys have really taken it up to the next notch, which is really inspiring. My question is, so for in our RAM, we relocated from the 17th floor to the first floor for about a year for a building issue, and our attendance went up by 100%. Wow. So my question is, you guys both mentioned your mobile. I think one or both of you had a mobile option for a while, and I'm wondering, notwithstanding the don't get into a van, do you consider that a further lessening of a barrier or more of a barrier? Because I would assume that, I don't know what I would assume actually. I thought it would be less, I guess.
So did we.
Okay.
But I actually think the location of the van is the thing. It's not the van that necessarily increases or decreases the barrier, but the location of the van that does. I think that would be our biggest learning. I know there are other communities across the province. We're not the only ones with a mobile clinic van. So this is just the world according to Kristen and Stonehenge. But for us, the van itself is a great modality. And it's easy for people to get to. We can bring it to people, which is wonderful. But the location is the thing that either improves it or makes it challenging.
Right? Because
Correct.
there's no anonymity to that.
100%. Yeah, you bet.
So I can speak to our program at Women's, and maybe Kristen can speak to Stonehenge. For us, that was a very important part of the partnership. We recognized not only did we not have the skills to kind of train and mentor, but that community of support would be really important. And actually, Women's College does have one other peer, but it's a completely different model. It's in a sort of refugee health clinic. So through Craftsman, which is our partner, the peer worker has received a lot of training, participates in regular meetings, has a supervisor with regular check-ins, and has access to other kinds of supports when they need them. We've really tried to develop. I guess it's an informal, just kind of take time and opportunity to share, but because all of us, I think, at times experience different kinds of vicarious trauma. But you're right. I think there are some additional considerations when it comes to a peer and what they, feel that they can do in terms of their scope. So that's how we're doing it. I feel like it's a good step. I haven't heard that it's feeling like it's not enough. But I think your question is a really important one also for anyone working in an organization and just thinking about how we manage grief and losses and take time to support each other. Not taking away from the peer, but just thank you for mentioning that overall.
Sorry, I wanted to add one thing to that is a half memory that I hope someone will correct if I'm wrong. Support House is a Canadian organization that I think does training and support to peer support worker, I believe. Supporthouse.ca, I think, is the URL. So that might be, and they specifically for peer support workers. So that's another resource that might be useful.
Yeah. Sure. I don't know if you have anything else to add.
I do. I think for us, what I think is important in relation to peer support is we just see it as another discipline within the staff team at our organization. And each discipline requires different levels of support and supervision and resources. So in relation to, and we're lucky because we do have peers in every program area at Stonehenge at this point in time. So we have internal community of practice for our peers. We have peer-specific supervision, so they will have supervision with their direct supervisor, but then also in relation to their peer work and what that looks like. There's training for the peers that they go through. They can receive a certification. There's different levels of that. We also have training for the supervisors who provide supervision. I think so. The answer is there's a lot that's needed. And I think that would be true if you were to think about that in relation to any other discipline that's working within your organization. You just need to think about what's specifically required for them and what they need. And I echo Jennifer's point around vicarious trauma being important for any discipline across an organization.
Contraception salt and prevention we wouldn't exist. Someone mentioned earlier about the unlawful and
I can say heard on all counts. I know what you're doing. I know how hard it is to pull together those partnerships and then how fraught they can be, right? If they start to kind of fall apart for any reason. Mhm. Well, it speaks directly to the impact of the work that you're doing too, and obviously the trust that you've developed. Thank you for sharing that story. I just want to say that focus of the RAM evaluation that Sarah was touching on is to collect these stories. I think we want to find ways to collect more of the actual stories than just the data. And using them to highlight the work that's being done and to advocate with the ministry for what needs to happen in terms of funding. It's not funding for Medify, it's funding for RAMs, and as well what Medify needs to do in terms of supporting RAMs and looking at helping other clinics meet those targets. So I don't know if you want to add to that, Kate, but thank you for sharing those stories. Yeah, we're at time. Thank you, everyone, for joining. We will still be here for one more session. Have a great rest of the afternoon.